Please welcome Professor Jamie Cavenagh to give us his reflections on 25 years.
Well, thank you for that, Gordon. I have to say, when I got up this morning, I was still uncertain what I was going to wear. Anyway, first, let me say what a great honour it is to be inducted into this august Hall of Fame. The theme today is to review the last 25 years of myeloma and to look at what might be happening in the next 25 years. As it happens, I've been involved with myeloma for over 35 years, and my first exposure occurred at the Marsden Hospital, where I worked as an SHO. Of course, the Marsden is, as we all know, the home of high-dose melphalan. I worked for Ray Powles and the late, great Tim McElwain. And it was Tim McElwain who first proposed the concept of high-dose melphalan. And his hypothesis was that possibly the worst way of treating a cancer was to give continuous low-dose chemotherapy, which is relatively ineffective and would almost inevitably result in resistance. So the concept was to give the maximally tolerated dose of melphalan in one go to achieve maximum response. And on reflection, it's curious to me that we have now moved back to a continuous therapy paradigm. Basically, patients now, many of them can expect to be on continuous therapy from the time of diagnosis. And I think we've lost something there. The treatment-free interval following a stem cell transplant was the patient's best time, despite the fact we know that progression-free survival is obviously impaired. Another thing about my time at the Marsden is I recollect performing numerous bone marrow harvests. Now, that wasn't the most intellectually stimulating activity, but I did develop extremely strong fingers. I would note in passing that the advent of peripheral blood stem cell harvest was a major advance and is sometimes somewhat overlooked. From the Marsden, I moved to George's, where I developed my interest in aplastic anemia and other bone marrow failure syndromes under the tutelage of Ted Gordon-Smith and Judith Marsh. Whilst working in the lab on my MD, which was on AML, I might add, I first met Kui Yong, who came to George's to complete her clinical training. Over the years, of course, we've gone on to collaborate on numerous myeloma clinical projects. From St George's, I moved to the Royal London Hospital as a lecturer and subsequently consultant, where I worked primarily with Adrian Newland and Steve Kelsey. I'm not sure I really learnt much about myeloma from those two, but Adrian certainly taught me the art of delegation. One of our SHOs at the London was a certain Heather Oakerby, who went on to become my longest-serving colleague. I think it's fair to say that over the years, our thought processes about myeloma and indeed other hematology aspects have almost become symbiotic and identical. We relocated to Barts in 1997, and at that time, I was the only consultant at Barts treating myeloma. And what treatments did we have? We had oral melphalan and prednisolone, or VAD, or VAMP, or CVAMP, and stem cell transplant. At that time, the median overall survival for patients was 2 to 3 years, or perhaps 4 to 5 years for patients who were young enough to have transplant. So over the last 25 years, outcomes for our myeloma patients have been transformed. And this is due to the introduction, as Neil has summarized already actually, of 3 and now 4 novel classes of agents. First, thalidomide. The seminal paper, which first described the efficacy of thalidomide, was published in 1999. And in fact, we at Barts, we treated our first patient with thalidomide in 1999, and I remember him well. He had had 2 autografts. He had had copious amounts of DNA-damaging agents. He was profoundly pancytopenic, red cell platelet dependent. He responded beautifully to thalidomide and survived for another 7 years. Of course, the concept the rationale for using thalidomide was that it was an anti-angiogenic agent. And anti-angiogenesis was a very popular concept at the time for treating a whole range of cancers. Of course, we now know that's not how IMiDs work. And much later on, in fact, we learned that IMiDs operate by binding to cereblon and initiating the selective proteasome-mediated degradation of selective proteins, perhaps importantly across an ileos. Since then, numerous cereblon binding agents have been developed, and I would stress that the clinical impact of Revlimid and pomalidomide in particular has been transformative over the last few decades. In early 2000, I spent time at the Dana-Farber Cancer Institute in Boston, where I first met Paul Richardson, who had recently been recruited by Ken Anderson. To be honest, at the time, Paul didn't really know much about myeloma, but as we all know, he rapidly became a global superstar in myeloma drug development. In the lab at the Farber at the time, there was much excitement about a new compound called PS341. This had been invented and developed by a certain Julian Adams who worked at Postscript. It turned out PS341 is a proteasome inhibitor. Now, to be honest, I'd never heard of a proteasome before I went there. And this drug later became termed bortezomib, or Velcade. I think it's absolutely fascinating that both the IMiDs and the PIs share a broad mechanism of action involving interaction with physiological protein degradation pathways. Who would have thought of that as an anti-cancer treatment? Anyway, bortezomib was at the time, and I think possibly still now, the fastest drug to go from lab to license. And that was on the basis of the pivotal APEX trial published in 2004. In retrospect, it's fascinating to note that the best available therapy, i.e. the other randomized treatment on that trial, was pulse dexamethasone, where patients received 4 days of 40 milligrams dex in multiple pulses. Anyway, later, I was at the NICE appraisal for bortezomib, and I do recall that one of my patients from Barts was the patient representative. He appeared slightly late, I might add, proudly wearing his Barts wristband, and when asked to speak, he said, I've just come from receiving my Velcade at Barts, and that shut him up a bit. And he then said, it's not for me to say whether I will live any longer because of the Velcade, but I have been able to work and continue to chair a number of companies, one of which owns this building we're sitting in. Anyway, so we went on to develop a combination using Velcade, Adriamycin, and dexamethasone. And this was predicated on the in vitro synergy between DNA-damaging agents and proteasome inhibition. So we struggled, actually, with the appropriate acronym here. If we use Velcade, it was VAD. If we use bortezomib, it was even worse. So we reverted to PS341 and called it PAD. We published the phase 1 study in 2005. Interestingly, the phase 1 component was the doxorubicin dose. One of the authors of that paper was Rakesh Popat, and indeed the author of the subsequent long-term follow-up paper, who's gone on to set up and develop an outstanding clinical trials unit at UCLH. I'm pleased to say that PAD is still there in the NCCN guidelines as an option for first-line therapy. The third class of drugs, of course, are the antibodies, particularly DARA and isatuximab. We participated in the Gen 503 phase 1 study for DRD for previously treated patients. The first patient we put on that trial, he'd relapsed less than 18 months following a stem cell transplant, and he is now on cycle 150 plus with ongoing complete biochemical remission. albeit with somewhat saggy counts, I would add. So I think the introduction of DRD for first-line treatment for our older patients is a real game changer. The fourth class of drugs are the T-cell redirecting therapies, CAR-T, T-cell engagers. These compounds have already demonstrated great promise, and I think how best to incorporate them into our future treatment pathways will be the subject of extensive clinical research over the coming years. Okay, now back to Bart's. We now have a team of young, energetic, and highly talented clinicians on the myeloma team. I'm certain that the future of myeloma therapy is safe in their hands and in the hands of their colleagues around the UK and globally. In fact, I can see some of them in the audience here. Simon, Katerina, yeah, I can't see anybody else. I think some of us are online. I'd also highlight the role that Marissa Farrell plays in our team. She's an outstanding CNS, and she certainly knows more about myeloma than most of us. Finally, I'd like to thank my wife, Annemiek, who is here today, but she's not allowed in the coffee room because she's not a UKMS member. She's had to put up with me for these 35 plus years, reading countless blood journals and wittering on about obscure hematology topics. Anyway, to conclude, the last 25 years has been a blast. Let's wait and see what the next 25 years brings, but I'm certain there'll be some surprises along the way. Thank you.
Disappointed that I didn't bother putting a suit on today. But anyway,